Hello everyone and welcome to a new lecture. The words are trachea and its role in ventilation. Chapter contains the pleural cavity, the trachea and bronchi, the lungs, mechanism of ventilation. Starting with the pleural cavity, the two lungs occupy the right and left pleural cavities in the thoracic cavity. They are separated by the central mediastinum containing the heart and great vessels, the trachea, and other structures passing through the thorax to the abdomen. The left and right pleural cavities are entirely separate from each other. Figure shows how they are formed as the developing lungs buds invade part of the coilomic cavity by pushing a layer of the wall before it. This is analogous to pushing your finger into a partially inflated balloon. Your finger is the equivalent of the lung bud. The wall of the balloon is the inner layer of the pleura, and the far wall of balloon is the outer layer of the pleura. The pleura are thus divided into outer and inner layers. As outlined in the figure, the outer parietal layer lines the inner surface of the thoracic wall, the thoracic surface of the diaphragm, and the medial wall of the mediastinum. The inner visceral layer closely covers the surface of the lungs. The pleural cuff is formed where the two layers become continuous. At the junctional region, surrounding the root hilus of the lung, a fold in the pleural cuff called pulmonary ligament allows some space of movement of the lung relative to the mediastinum during ventilation. The pleural cavity separates the two layers of pleura, but is normally a potential space over mediastinum of the lung surface. The visceral and parietal pleura are in virtual contact, separated by only a thin layer of pleural fluid. Pleural fluid has two important functions. It lubricates movement of the lungs and their attachment visceral pleurae against the parietal pleurae. It also adheres the two pleural layers to each other, thus maintaining the inflation of the lungs. The parietal pleurae is often described as having costal, diaphragmatic, and mediastinal surfaces. This is useful when understanding their nerve supply. The costal pleura is supplied segmentally by intercostal nerves, the mediastinal pleura by the phrenic nerves, and the diaphragmatic pleura centrally by the phrenic and peripherally by the lower 5 intercostal nerves. The visceral pleura is insensitive to pain and touch, as it only receives an autonomic vasomotor supply. The effects of lungs, diseases, and infections on the pleura are described. The effects of failure of adhesion between pleural layers is described. Development of the lungs and formation of the pleural cavity, developing trachea, parietal pleura, lung bud, and visceral pleura. Visceral pleura, pleural cavity, pleural cuff, hilus. Lung infection and pleurisity. Disease states of the lung, example pneumonia, are often painless until they reach the surface of the lung and the pleurae become involved. Local infection of the pleural cavity may lead to a breakdown of lubrication between pleural layers. Lack of lubrication can produce a painful pleural rub, audible through a stethoscope, and adhesions between the two pleural layers due to the formation of fibrous scar tissue. The pain is referred to the cutaneous distribution of the segmental nerve supply, the pleural area affected. The pain experienced may be referred to the abdomen via the lower 5 intercostal nerves, or to the shoulder via the phrenic nerve. General infection of the pleurisy is often painful. Interestingly, pleural pain may be abolished by applying local anesthetic to the appropriate skin area. Pneumothorax. The pleural cavity may become infiltrated by air, excess pleural fluid, blood, or pus. The effect will be the same irrespective of the infiltrating agent. The pleural fluid will either be no longer in a thin enough layer to maintain adhesion or will be displaced by a non-adhesive agent. The two pleural layers will pull apart and the lung will collapse. A pneumothorax is produced when air enters the pleural cavity, usually by a diseased lung, much less commonly by the ends of broken ribs, and even less frequently by stab wounds through the chest wall. Spontaneous pneumothorax may occur in healthy lungs after a great exertion. The most dangerous type of pneumothorax is where the ruptured lung has a valvular effect, allowing air to pass from the lung to the pleural cavity, but not vice versa. This is a tension pneumothorax and leads to progressive buildup of pressure in the pleural cavity and hence collapses of the lung. Effects include breathlessness and pain because of the mediastinal structures are displaced towards the opposite side. Pleural effusion is excess serous pleural fluid, usually stimulated by lung disease. Secondary infection of the excess fluid is common. Thus, empyema and/or blood hemothorax may also infiltrate the pleural cavity from lung infections. Fluid or air is usually aspirated from the pleural cavity by means of pleural tap. A wide-bore needle is inserted laterally through a lower intercostal space so as to pass into the pleural cavity beneath the lung, above the diaphragm. The needle is placed above the rib, forming the lower margin of the relevant intercostal space, so that it is well away from the intercostal neurovascular bundle running beneath the rib below. The trachea and bronchi. The trachea is the first part of the lower respiratory tract. The figure shows its course. The trachea starts at the lower border of the larynx, denoted by the cricoid cartilage in the neck, and runs down in the middle line to enter the thorax, deep to the sternal notch. After a relatively short course in the thorax, it bifurcates into left and right main bronchi at the level of the sternal angle esophagus, left recurrent laryngeal nerve, trachea, arch of aorta, right main trunk of the trachea, upper lobe, bronchus, middle lobe, lower lobe, heart, lower lobe, upper left main bronchus. The trachea and esophagus and structures related to them. The trachea is about 2.5 cm in diameter in adults. It is easier to remember that the internal diameter of the trachea is about the same diameter of the patient's little finger. Especially if you need to create an emergency airway, the trachea is reinforced by C-shaped rings of cartilage. The open side of the C facet posteriorly to allow the esophagus, which lies immediately behind the trachea, to dilate during swallowing. The wall between the rings is made up of fibrous tissue and smooth muscles. As expected for component of the respiratory tract, the lumen is lined by respiratory epithelium. As you can see, the two main bronchi are not identical in size or position at the tracheal bifurcation. The right main bronchus is shorter, wider, and more vertical than the left bronchus. The left bronchus is supplying 2 lungs as opposed to 3 of the right, and the left lung is displaced laterally by the heart, thus making more of an angle between the left bronchus and the trachea. The left main bronchus is about twice as long as the right. Box describes how the anatomy of the main bronchus influences the likely destination of inhaled foreign bodies, outlines the added complications in unconscious patients. The right and left main bronchi divide within the substance of the lung into lobar bronchi supplying each lobe. The structure of the walls of the bronchi is similar to that of the trachea, although the cartilages become increasingly irregular below the bifurcation. The lobar bronchi divide again into segmental bronchi, each supplying a bronchopulmonary segment. Each lung is divided functionally into a number of these segments, each supplied by its own segmental bronchus and accompanying blood vessels. Each segment thus forms an individual functionality. If disease is restricted to one or two adjacent segments, they may be removed by a thoracic surgeon with a minimal loss of blood or leakage of air from adjacent lung tissue. Foreign bodies in the lower respiratory tract. Foreign bodies entering the larynx and trachea will stimulate a powerful cough reflex. The ridge formed by the bifurcation of the trachea is the last area to contain sensory nerve endings capable of eliciting the cough reflex and may thus be considered a last line of defense. In reality, small objects that pass the larynx are likely to continue down the trachea to its bifurcation. When foreign bodies do pass the bifurcation, they usually enter the right main bronchus, because it's wider and in a more direct line with the trachea. If the patient is upright, the foreign object will usually enter the lower lobe bronchus. If they are lying down, as in common in many dental procedures. The project may enter the right middle lobe bronchus. An inhaled foreign object may block one of the bronchi, leading to the collapse of part of the lung or may cause a lung abscess if the object is infected. Reflexes in unconscious patients. The cough reflex is in abeyance in unconscious subjects. Blood or other foreign objects. Example, tooth fragments may enter the lungs in the victims of road accidents and other violence without stimulating the cough reflex. The vomiting reflex is virtually the last reflex to be suppressed, even in deeply unconscious subjects. They may therefore vomit and then inhale it without eliciting the cough reflex, with the potential to asphyxiate all their own vomits. To avoid this potentially fatal event, it is vital therefore to place unconscious subjects in a recovery position if it is safe to do so and their injuries allow. In the recovery position, the patient is laid prone with their head turned to one side, propped by one of their arms, the knee on the side to which their head is turned is bent. To ensure they do not roll over, the recovery position ensures that if the patient does vomit, the vomit will leave their mouth and not enter the lower respiratory tract where the unconsciousness can be and often are fatal. When a patient is given a general anesthetic for dental extraction, procedures must be adapted to ensure that tooth fragments and other foreign bodies are not inhaled. The thorax is packed or an endotracheal tube is passed. The lungs. Both lungs are covered by visceral pleurae which adhere tightly to their surfaces. As we have already seen in figure, each lung is conical with a blunt apex projecting about 2.5 centimeters above the medial third of the clavicle, a concave base over the diaphragm, an extensive convex costal surface, and a concave mediastinal surface. In fixed post-mortem lungs that you may see in a dissecting room, evidence of the structures adjacent to each lung can be seen as grooves molded around the ribs and aorta, for example. These markings are of course not present in the living where the lungs have a texture rather like sponge rubber. The left lung is slightly smaller than the right because the heart decreases the size of the left pleural cavity. The left lung has a recess, the cardiac notch, in its medial side which accommodates the heart. As already described in section, both lungs are divided by an oblique fissure into upper and lower lobes. The upper part of the right lung is subdivided by horizontal fissure into upper and middle lobes. The root of the lungs. The lung root, also known as the hilus, is the communication between each lung and the rest of the body. The roots of the right and left lungs are shown schematically. The main bronchus enters each lung root with a corresponding pulmonary artery carrying the oxygenated blood from the heart. Two pulmonary veins leave the root carrying oxygenated blood back to the heart. A small bronchial artery accompanies or is embedded in the wall of each bronch First, the pattern of vessels and bronchi entering and leaving the ileus is very variable, depending on how close to the lung surface the incision is made to remove the lung to view its route. In addition, it is very difficult to distinguish pulmonary artery and veins from each other. On anatomical specimens, because their walls are of similar thickness, the bronchi can be distinguishing without difficulty, as they are reinforced with cartilage, which can be felt quite easily. And thank you for listening to this amazing lecture of reading anatomical books for dental students and anatomy.